All right, let's dive right in. Today we are cracking the case on a skill that is absolutely fundamental for any clinician, the musculoskeletal assessment. We're going to break down this step-by-step process that literally turns you into a detective of the human body. So, how do they do it? How do clinicians figure out what's really going on inside a person's body? Well, they become clinical detectives. Every time you're with a patient, it's an investigation. Your goal is to gather clues about their pain and injury, how they function, to solve the case. And like any good detective, you can't just wing it. You need a reliable field guide, a system to make sure you don't miss a single crucial clue. This guide is what helps us make sure our investigation is thorough and, just as importantly, efficient. At the very heart of this field guide is our essential mnemonic. It's IPRMSF. That's inspection, palpation, range of motion, muscle strength, special tests, and functional assessment. This is it. This is our checklist for cracking any musculoskeletal case that comes our way. Every single investigation starts the moment you see the patient. So before we even get hands-on, we're just observing. We're setting the scene, making sure the patient is comfortable, and then we're making our first big picture observations from a distance. This is what we call the general survey, and it's all about watching. First, just look at their posture. How are they holding themselves when they stand up, when they sit down? Then, you're going to watch them walk. Is their gait, their walk, is it smooth? Is it symmetrical? Do both arms swing the same way? And finally, take a look for any mobility aids. A cane, a walker, a brace. These are all huge clues about how they're functioning day to day. Okay, so after that initial survey from afar, it's time to get up close. And this brings us to the I and the P in our mnemonic, inspection and palpation. We're about to combine what we can see with what we can feel to find much more specific evidence. It's amazing how much our eyes alone can tell us. During the inspection, we're scanning for those obvious signs of inflammation, like swelling or redness. But here's the crucial detective technique. You have to compare one side of the body to the other. Always. Is there any asymmetry? Do you see any obvious deformities? Or maybe some unusual curves in the spine? A really key part of inspection is comparing the muscle bulk on both sides. If you see atrophy, which is just muscle wasting, that can be a major red flag for nerve problems, or even just that the muscle isn't being used. And on the flip side, you have hypertrophy, where a muscle is bigger. Now that could just be from exercise, or it could be a clue that one muscle is working overtime to compensate for another one that's hurt. Now we bring in our hands. Palpation, or touch, can uncover clues that are totally invisible. We can pinpoint exactly where it's tender, feel for warmth that screams inflammation, and detect something called crepitus. That's that kind of grating, crunching feeling in a joint. We can also feel the muscle tone itself. Are there any tight spasms or little knots? So we've looked and we've felt. Now it's time for the interrogation phase of our investigation. This covers the R and M in our guide, range of motion and muscle strength. We're going to actively test what this system is really capable of. Okay, so first is active range of motion. This is where the patient does all the work. It tells us what they can do and what they're willing to do. Now, if they can't move a joint all the way, we then perform passive range of motion. And here's the critical distinction. If you can move their joint through a full range, but they can't do it themselves, the problem probably isn't the joint. It's more likely a muscle weakness or a tendon issue. That's a huge clue for your diagnosis. To make sure all clinicians are speaking the same language, we need a standardized way to talk about our findings. And for muscle strength, that language is the 0 to 5 scale. A 5 is totally normal, full strength. A 3 means they can move their limb against gravity, but not against any of your resistance. And it goes all the way down to a 0, which means you feel no muscle contraction at all. Sometimes all the initial clues start pointing to one very specific suspect, maybe carpal tunnel syndrome or a specific torn ligament. When that happens, it's time to bring out the specialized tools for some advanced detective work. This is the S and F from our mnemonic, special tests and functional assessments. They're designed to prove or disprove our theories. A sit-to-stand test, for example, is a great functional assessment of real-world mobility. A straight leg raise, on the other hand, is a special test designed to provoke a very specific nerve to see if it's irritated. These are so useful when you have a pretty good idea of what's going on and you just need to confirm it. Okay, I want to pause here for a critical safety announcement. This is important. In any situation where you even suspect a major injury, like a broken bone, there is one check that is absolutely 100% non-negotiable: your CMS checks. CMS stands for circulation, motor, and sensation. You're checking for good blood flow, their ability to move, and that they have normal feeling distal to the injury, which just means further away from the center of the body. So if you think an arm is broken, you check the hand. If you think a leg is broken, you check the foot. And let's be crystal clear. This is so much more than just checking a box on a form. A fracture or a lot of swelling can actually squeeze and cut off the nerves and blood vessels running past it. If you miss that, it can lead to permanent muscle damage or even nerve loss. The CMS check is a vital safety net. So, our investigation is almost done. We've gathered clues from looking, from feeling, and from all our tests. The final step for any detective worth their salt is to put all that evidence together into a clear, coherent report, and that is documentation. Your report, your note, it has to be clear and objective. You'll want to mention if your findings were symmetrical or not, record any specific limits you found in their range of motion, and of course, always use that 0 to 5 scale for strength. But maybe most importantly, you need to connect your findings back to the actual person. How does all this affect their ability to walk their dog, get dressed, or go to work? That's the part that really matters. And there you have it. The investigation is complete. We've followed all the steps, we've gathered the clues, and we've documented the evidence. But now, the real work begins, interpreting all that evidence to write the final chapter of the story, the diagnosis and the plan. So the question is, what story will your clues tell?